Raja, second year surgery resident in Saga Hospital. Today I am going to discuss about the thoracic trauma. I am going to discuss about the incidents and different mechanisms of injury of the thoracic trauma and assessment and their management. Chest trauma, it is a life-threatening condition which is explained initially by the complexity of the thoracic lesions and related respiratory failure. And it is also explained by consequences of the hypoxemia and inflammatory reaction on other organ functions. And the lesions association require rapid and efficient patient management for the assessment of the severity, pain management, and the management of the hypoxemia and appropriate management. And the thorax, that include three main systems, which are airway and lungs and cardiovascular system. The trauma to the any of these structures which leads to the life-threatening condition unless until if it is rapidly identified and treated. And there are 20 million people are hospitalized every year because of the injuries, out of which 1 million people are dying because of the trauma-related injuries. And these traumatic injuries leads to 5.8 million deaths each year, which accounts for 10% of the world's death. And in India, we are noticing about the trauma-related death reported every 1.9 minutes. And out of all the traumas, chest trauma accounts for 10% of the all trauma admissions, and in which 25 to 50% of the deaths we are noticing, of which there are 25 patients associated chest trauma are associated with directly related to the mortality, and in another 25% of patients, this is acting as a contributing factor. And majority of the patients, around 80%, can be managed with appropriate analgesia and respiratory support and intercostal chest tube drainage.
If you can stop there,
yes, sir.
Go back.
Yes, sir.
It's important for you to understand, not just during your post-graduation, even after you qualify and go out to your native cities independently when you are practicing.
Yes, sir.
You don't have to panic when you see a patient with chest trauma. Large majority can be managed by you guys wherever you are, provided you know how to recognize, yes, there is an injury, what is the type of injury, what needs to be done. And recognize a patient who has tachypnea, breathing difficulty, easy to measure saturation these days. Saturation probes are available in pocket size. Recognize and treat the hypoxia and wait for the injuries to heal. And if you know how to put a drain and take out the chest drain, large majority you can manage wherever you are without having to refer. Yes, that's the crucial part here.
Yes.
Okay. Thank you.
Okay.
Continue.
Yes, sir. And thoracic trauma, it can be categorized by different mechanisms that includes blunt trauma and penetrating trauma. In blunt trauma, the most common causes motor vehicle collisions, that are road traffic accidents, and fall from heights, vehicle striking, act of violence, and blast injuries, and it also includes inhalational injury. And penetrating trauma are caused by gunshot and stab injuries. Blunt trauma is most commonly seen when compared to the penetrating trauma. It comprises of around 20 to 25% of all trauma deaths. The higher morbidity and mortality associated with high-speed collisions who are with lack of seat belt. And blunt trauma to the chest who require operative intervention is less than 10% of the people, and around 15 to 30% of the people who are with penetrating chest injuries will need operative intervention. And the penetrating chest trauma is associated with higher mortality when compared to the blunt chest trauma.
Indraja, you mean to say intervention?
Yes.
Operative intervention is a major intervention in the form of a thoracoscopy or a thoracotomy or a sternotomy.
Yes, sir.
Chest drain is not included here.
No,
okay.
No.
So even the penetrating trauma patients, not all of them require a major surgery in the form of a thoracoscopy or a thoracotomy. They can also be managed with a simple chest drain, oxygen supplementation.
Yes.
Okay, continue.
Okay. And when come to the anatomy, the major components of the chest wall include rib cage, costal cartilage, and intercostal musculature. And it also includes neurovascular bundle, which includes the intercostal arteries, veins, and nerves, which are run along the inferior border of each rib. And deep to the rib cage, there is a parietal pleura, which lines the inner wall of the chest wall. And the visceral pleura, it covers the intrathoracic structures, and the space between the visceral and parietal pleura is known as pleural space. It consists of hypotonic fluid around 0.3 ml per kg, which produces at a rate of 0.15 ml per hour. And this fluid is produced by the parietal pleura and is reabsorbed by the pleural lymphatics. And the chest wall has two main functions, like it facilitates the respiration and protects the intrathoracic structures. During inspiration, there is contraction of the diaphragm and it increases the intrathoracic volume and decreasing the intrathoracic pressure that allows the entry of air into the lungs. And during expiration, diaphragm relaxes and volume, intrathoracic volume decreases and pressure increases that drives the air out of the lungs. And the sternum and clavicle protects the anterior thorax and scapula protects the posterior chest wall. There are different mechanisms of the injury in blunt trauma, which includes deceleration, crush injury, and blast injury. And deceleration injury is most commonly seen in case of the blunt trauma. This is the injury in body, body in motion strikes a fixed object. That these to the blunt trauma to the chest wall. These internal structures are continued in motion. And in crush injury, the body is compressed between an object and hard surface. There is direct injury of the chest wall and internal structures. And in case of the blast injuries, these pressure waves causes a tissue disruption that causes tear of blood vessels and the alveolar tissue, disruption of the tracheobronchiality, and also causes diaphragmatic rupture. There are different conditions which include.
Hold on. Are there any questions from any participants? You need to raise if you have any questions as she presents. Please don't sleep. Okay, continue. Slow down a little. Yeah.
Okay, sir. And there are different conditions which are developed followed by the chest trauma. This includes immediately life-threatening and potentially life-threatening. The immediately life-threatening means the patients will need intervention immediately to save the patient's life. These includes tension pneumothorax, pericardial tamponade, open pneumothorax, massive hemothorax, and pleural chest. And the potentially life-threatening conditions which can manage after stabilizing the patient. These includes aortic injuries, tracheobronchial injuries, myocardial contusion, rupture of the diaphragm, esophageal injuries, and pulmonary contusion. And the assessment of the thoracic. Yes, sir.
Just go back. What she means to say is immediate life-threatening injuries is a clinical diagnosis diagnosed in the casualty when you are with the patient, and you have to treat it there and then. You can't wait for a chest X-ray. You can't wait for a CT scan. You can't wait for an echo. If you suspect tension pneumothorax, you need to decompress and then put a drain. If you suspect cardiac tamponade, you have to do subxiphoid pericardiocentesis, like that. So these are clinical diagnosis, and action must be taken there and then without waiting for any investigations. Potentially life-threatening, yeah, you need to investigate thoroughly, maybe a CT scan, maybe an echo, and then decide what the plan of action. That's what she means to say. Okay. Next.
Yes.
Continue.
And the assessment of the thoracic trauma patient can be started by the primary survey, which includes the assessment of the airway, breathing, circulation, and disability and exposure. We have to stabilize the airway with cervical spine protection and hemorrhagic control. And we have to stabilize the patient according to this protocol. And
wait, I think it needs a special mention here.
Yes, sir.
ABCDE is the ATLS protocol that is well known to, I'm sure the UPGs are aware of it. H is placed in the brackets. A next to it is H. Means hemorrhage control takes a priority in a small subset of patients in trauma, like amputation of a limb with an arterial spurt bleed. You cannot allow that patient to bleed and become avolumic and die. That arterial bleed must be controlled instantly with a splint, some form of, I'm not telling you to take her to OT or take these artery suture materials and fix it. Some form of splinting should be done to stop that arterial bleeding. That is H in the bracket, hemorrhage control. I mean to say, if you see a patient with a scalp laceration or an avulsion injury where there is a little bit of dripping of venous blood, you don't give priority for that. H, stopping torrential, life-threatening bleeding as in amputated limbs. Not in all patients. Don't waste time with H in all patients with abrasions, lacerations, and all that. Okay?
Yes, sir.
Continue.
Yes, sir. And we have to stabilize the patient. Initial interventions include insertion of the large bore IV cannula and oxygen administration, and we have to monitor the patient carefully. And the adjuncts to primary survey, which includes the chest X-ray and EFAST, which is a focused assessment of the sonography of the trauma.
Does any senior answer go back? What were the adjuncts to primary survey in the olden days? Any seniors? Abdul, Hari, which 3 X-rays were considered to be important? Adjuncts to the primary survey.
Lateral spine.
Along with chest X-ray, 2 more X-rays were considered important. That used to be routinely requested in all the patients of polytrauma.
The spine and
X-ray abdomen.
X-ray cervical spine and pelvis.
Yes.
That being replaced now with either the EFAST or with a fast-track CT scan from head to knee. That's the most advanced trauma centers practice these days. Okay?
Yes, sir.
So chest X-ray, X-ray, cervical spine and pelvic X-ray were the 3 X-rays which were considered adjuncts to primary survey in the olden days.
Okay.
Not anymore. Next.
And the secondary survey, which includes the complete history and physical examination. The history includes the history about the allergies, medications, past medical history, and last meal, and investigations, events regarding the trauma. And we should inspect the trachea and chest wall. We should look the trachea whether any deviation is there or not, and we should inspect the chest wall whether any asymmetry is there or not, and palpate it for the tenderness, crepitus, or to detect any flail segments, and we have to auscultate the chest for the breath sounds. In assessing the circulation, if we are suspecting the hypotension in setting of the thoracic trauma, we should raise the suspicion of the tension pneumothorax or cardiac tamponade. And the further evaluation includes imaging like chest X-ray and CT scan of the chest and the ultrasound of the abdomen. Chest X-ray should be done to see to look for the any fractured ribs or to look for the any pneumo or hemothorax. And the sensitivity of the chest X-ray is only 65% in case of the detection of the acute traumatic injuries. CT scan has much higher sensitivity when compared to the chest X-ray, but the obtaining CT requires the transportation of the patient to the out of the emergency department, and this is not possible in case of the patients with who are hemodynamically unstable. The ultrasound focused assessment with sonography in trauma, it is important in initial phase of the trauma assessment. It detects pathological pericardial, intraperitoneal, and intrathoracic free fluid. And nowadays, the other technique is extended FAST, which employs additional chest views to evaluate the pneumothorax. In EFAST, they use linear ultrasound transducer probe when compared to the standard curvilinear probe. It has a higher frequency, enhances the visualization of the pleural space. Can I continue, sir?
Yeah, wait.
Yes, sir.
Yeah, who has raised the question? Nishant, speak about it.
Can I come in, sir?
Yeah, please.
Yes, sir. Sir, in one slide, she said that while assessing circulation, if it is hypotension, she only spoke about tension pneumothorax and pericardial tamponade. One must also keep hemothorax in mind when they're assessing. Just an additive to that. That's all.
Yeah, agreed. Any other comments?
Sir, if she can expand a bit on FAST, where all do they keep the probe and what are they looking at? Just so that for the benefit of everyone who's listening.
Indraja, do you have an answer for that? Which are all the quadrants on the abdomen? Do you do the ultrasound all over the chest or any particular area that you do? So this is a quick scan. You cannot spend minutes and hours there. Quickly see if there is fluid in the pelvis, quickly see if there is fluid in the costophrenic angle, like that. Which are all the areas in the body that they do the ultrasound?
Sir, no, sir.
I've already answered it.
Sorry.
Nishant,
In the like
In the pelvis, sir,
Pericard-
and both the side of paracolic gutter and in chest, and E-fast means if you include the chest with that, it is E-fast. If I'm not wrong, sir.
extended is include the chest along with the abdomen. Yeah. Earlier, it used to be look for hemothorax. Obviously, you look for hemothorax in the lower part, in the costophrenic recess. If you have looking for pneumothorax, obviously you look at the subclavicular region also, in the mammary and infraclavicular region.
Sir, may I come in, sir?
Yeah, go on.
Indraja,
Yes,
you
sir.
should just remember whenever there is a blunt abdominal trauma, what are the two solid organ injuries? Liver, spleen.
and spleen, yes, sir.
So in fast, what you do is perihepatic,
Hepatic and
perisplenic,
perisplenic area. Spleen.
pericardium, and then the pelvis.
Okay.
In E-fast, you just extend it to the chest.
Okay.
Like that.
I think
Indraja.
Yes, sir.
Nishant's point is extremely important. When there is hypotension, you have to consider significant major thoracic vascular trauma, and so that if there is hemothorax, it may be due to that also. So I think not just tension pneumothorax or pericardial tamponade, which are extremely important. You also have to think about major thoracic vascular trauma.
Okay, sir.
Because I think extreme degree of care and very emergent treatment may save the patient in these kind of situations.
Any other additions, comments?
If there is Rajashekar, as you said, mentioned very clearly, now all the advanced trauma centers will have CT scan along the emergency room and also the emergency operation theater. So taking them to CT scan may not be that difficult. So I think that is, if at all that is available, I think we should give up all this E-fast and all that and quickly take the patient to CT. If that is not available, then E-fast will be a good option.
In the era, say 10 years back or a decade back, where the CT scan were of low resolution, first generation CT scans, where a CT head used to take 2 to 3 minutes, then you want to do a CT chest, that will take another 4. It was a time consuming, and also CT scans used to be huge machines located far off from the emergency departments. All the currently built emergency departments will have an inbuilt 120 slice CT scan where head to knee CT is done in 10 seconds or 15 seconds. And these scans can be viewed by the consultants who are not in the casualty. That's the advantage. Most advanced centers will have the PAC system where you can access and see the scan and make your own decision. Most consultants would like to learn to read the CT images. That makes the difference. In the decade back, when this facility was not available, ultrasound was the quickest way of assessing the patient bedside in the casualty. That's where the fast and E-fast was available. So both are good. It depends on what facilities we have. My next question was, who will do the E-fast? So you don't wait for a radiologist who is not part of the emergency team in the management patient in casualty. E-fast is done by the doctors in the casualty. So the basic knowledge of ultrasound should be available to the most consultants and registrars in the casualty. And the machine should be available in the casualty for you to do, interpret, and then treat. Those are the limitations.
Okay.
Any questions?
No, sir.
Okay,
Yes.
Indraja, continue.
Okay, sir. And there are different types of injuries and their management. In the rib fractures, these are the compressional forces which flex and fracture the ribs at the weakest point. And the ribs 4 to 9 are the most commonly fractured, and 1 to 3 requires a greater force to fracture. And these 1 to 3 fractures leads to the injury to the underlying major vessels. And ribs 9 to 10 are less likely to be fractured, but these are most important. If these are fractured, we should suspect diaphragmatic injury and injury to the underlying abdominal viscera. And in the case of rib fractures, hypoventilation is common because of the pain. And these are the
Hold on. You are missing something. In the upper first
Yes,
rib to third rib fracture, it's neurovascular injury
yes,
that you have to rule out. What neural injury do you want to rule out?
Sir, behind the first rib, there is a brachial plexus, sir. Brachial plexus and
Brachial plexus injury, you cannot ignore that. Then the major vessels, thoracic outlet vessels, subclavian artery, subclavian vein, and others. Okay. Continue.
Yes, sir. And these are image showing the different levels of the rib fractures. And the sternal fracture, it is associated with a severe blunt anterior trauma, and it is followed by the direct blow to the sternum, which is tearing of the vein. And there is increased mortality if there is an underlying myocardial contusion, pericardial tamp node, cardiac rupture, and pulmonary contusion. And the flail chest, which is known as 3 or more ribs fractured at 2 or more places.
Wait. How do you want to treat a patient with rib fracture or a sternal fracture?
Sir, generally we'll manage conservatively, sir, if the patient is vitals, everything stable.
After having ruled out underlying visceral injury, after having ruled out potential complications like hemothorax, pneumothorax.
Yes, sir.
Once it is confirmed to be a simple rib fracture or a simple sternal fracture, then it's a symptomatic treatment.
Yes, sir.
Okay.
And the flail chest, which is known as fracture of ribs at fracture of 3 or more ribs fractured at 2 or more places. It results from the blunt trauma, and the diagnosis is made clinically in patients who are not ventilated, but not by radiography. To confirm the diagnosis,
hold on. Nishant wants to know
yes, sir.
indications for surgical intervention in rib and sternal fracture. Nishant, honestly, in the good olden days, even in displaced rib fractures and displaced sternal fracture, we never thought of fixing it because somehow they will unite. There is a growing available evidence, at least if they are displaced, it should be fixed. Maybe partly commercially driven because specially designed plates and screws are available today, both for the sternum as well as for the ribs. But the need or indication for internal fixation of a rib fracture or a sternal fracture is, we are seeing more and more patients from the IT industry who need to travel. You cannot abstain from air travel for 6 to 8 weeks, which is the convention for any chest injury or a intervention when you do on the chest. These patients, they cannot sit at home for 6 to 8 weeks. They may lose their job. Those select few patients, actually, if you do a plate and screw fixation of the rib fracture or a sternal fracture, within 2 weeks, they can go back to the work, even a flight journey also. That indication now is expanded to almost all the patients with displaced rib fractures. If the patient can afford and if we can fix it, pain will be far less and resuming the day-to-day work is much earlier. Needless to say, if there is a major flail segment or if you are doing an intervention like thoracotomy for a hemothorax, all those are the conventional indications where you stabilize the ribs. Have I answered your question, Nishan?
Yes, sir. Yes, sir. Thank you, sir.
Okay.
Sir.
I thought more about the internal injuries, Nishan.
No, sir. It was regarding this only. Like when do we, if there is a overriding rib fracture, do we go in and do it like for clavicle?
Necessarily, you have to fix all patients.
Okay, sir.
Yeah.
Sir, one question, sir. Sir, for all the rib fractures, who are the patients who require CT for rib fracture, like multiple, or when do we ask for a CT?
All of them.
Okay.
All of them is not required actually. A patient with a chest X-ray shows no hemorrhage, 1 or 2 simple rib fractures undisplaced, you can send them home with a simple analgesics. You don't have to do a CT in all of them. But if you are suspecting more injuries, or if you are suspecting maybe a diaphragmatic rupture, or if there are multiple refractures, suspected lung contusion, you cannot see the lung contusion in the X-ray.
Okay.
1 or 2 refractures, simple fall, simple injury, you can manage on the X-ray itself. It
Okay.
is not required for all, Ravi. Sorry.
No, I meant anybody who comes to the hospital.
Comes to casualty in a tertiary specialized scan center like ours, probably justified. Agreed. Yeah.
Sir,
But is there any change for a young age or old age, sir? It's for same, sir. Like old age.
It is based on the injury, so how suspected you are about the internal organ injuries. That's the indication for CT scan, not the age of the patient.
Okay.
Sir, I have a question.
Hmm.
Sir, regarding this, if managed conservatively, not thoracoplasty, managed conservatively, how many of the ribs go into malunion or non-union?
It does not matter, actually.
It doesn't matter, sir.
We have managed up to 5, 6, or 7 rib fractures, moderately displaced. Patient can't afford to literally to get admitted and rib fracture stabilization. We have managed conservatively, and when they come for months and years down the follow-up, they are carry on with their life as usual. We have not done a PFT and a randomized study to say that. Large majority practicing clinicians agree, as long as he is able to carry on with his life, leave him alone.
Okay, fine. Thanks.
Cost comes in a big way if you really want to fix every patient with a rib fracture. That's the limitation, more of.
Okay.
Sir, can I ask? Sir, if
Yeah.
patient is insisting for the fixation, if
It is ideal, actually.
Okay.
Undisplaced, there is no indication. Displaced rib fracture, I would not hesitate to put a plate and screw. Specially designed plates and screws are available these days. I would go ahead and fix it.
Okay.
There's nothing harm in it. These demands come rarely in our practice, but these are the patients who need to travel frequently by flight. They are the ones who need this treatment.
Okay.
Okay.
Yes, sir. Okay.
Yeah.
Okay. Shall I continue, sir?
Yeah. And the flail chest, what was your description?
Sir, these people have paradoxical respiration, sir. The chest wall moves inwards during the respiration, like particular segment of the chest wall, because there is a consecutive rib fractures at one or more places anteriorly and posteriorly, and that part of segment moves inwards during the respiration, sir.
Oh, I think let me take 1 or 2 minutes to explain. Not necessarily the ribs, even the sternum can break with the fracture of the ribs on either side, and central sternum also can act as a flail chest. Basically, 2 or more adjacent ribs have fractured not in one place, in multiple places, meaning to say that segment of the chest wall has detached itself from the remaining rigid chest wall. Okay, so if you remember, there is negative intrapleural pressure always.
Yes, sir.
Highest during inspiration. Ordinarily, chest wall expands during inspiration and collapses during expiration. But when one segment of the chest wall detaches itself from the remaining rigid chest wall, it draws inwards during inspiration. That's the paradoxical moment.
Yes.
So when that segment goes in against the lung expansion, obviously breathing will be difficult. So for multiple ribs to fracture at multiple sites, force of injury is also higher, meaning to say the underlying viscera are also likely to be injured in the form of a lung contusion, hemothorax. These are the patients which definitely require CT scan, admission, observation at least for few days. Invariably, all of them require oxygen supplementation, chest drain insertion, etc. If you need to understand the mechanism, what does it mean by paradoxical movement, and why is this flail chest is so significant? When you see them in the casualty, you cannot brush aside and send them home with analgesics because the saturation was normal at that time. When they initially come to the casualty, the saturation may be normal, 95, 98 at room air. But if you see a flail chest, you cannot just discharge them without admission and observation. That's the idea. Continue.
Yes, sir. So the gold standard investigation for the flail chest is CT scan with contrast, which display the vascular structures and
Vakka nimshimama. Shrikant, that's what I told you. The chest is a rigid cavity because two or more adjacent ribs are fractured multiple places. That segment of the chest wall becomes free from the rest of the rigid chest wall. So that segment moves inside during inspiration, outside during expiration. That's what paradoxical movement. Shrikant, can you come online?
Unmute Shrikant. Yellappa, question kelbutelo otogidiya.
He is talking, sir, but it is not coming actually. His audio something. I can see his video.
Unmute madakelo.
No, sir. Somewhere is unmute. He is unmuted, but he is not showing, sir.
Okay. Rajashekar.
ಇಲ್ಲ ಕೇಳಿಸ್ತಿಲ್ಲ ಶ್ರೀಕಾಂತ್. ಸರಿ ಹೋಗ್ಲೆ, ಕಂಟಿನ್ಯೂ ಇಂದ್ರಜ.
Yes, sir.
One question. Because of the reduction in the negative intrathoracic pressure, which also has a major determinant in venous return, will there be hypotension also?
Invariably, there will be hypoxic, hypotensive, lung contusion. All the combination factors will be there in these patients to some degree or the other.
Yeah.
So when you see a patient with flail chest, you be serious and don't then send them home because the patient requested. At least document that there was a flail chest, we advised admission and the patient has refused. Continue, Indraja.
Yes, sir. Okay. And the management includes oxygen administration and adequate analgesia. And we can give the topical intrapleural local analgesia through the intercostal chest drain. And ventilation is indicated in patients with severe respiratory failure. And surgery to stabilize the flail segment using internal fixation of the ribs may be useful in case of severe chest injury and pulmonary contusion. And simple pneumothorax, it is also known as closed pneumothorax. It occurs when the lung tissue is Can I continue, sir?
Indraja,
Yes, sir.
should also mention, I think in patients who have significant multiple segment, flail chest rig fractures, I think thoracic epidural as an analgesia is extremely important. I think that will give them a lot of relief.
Okay, sir.
Agreed.
Okay. Simple pneumothorax, it occurs when the lung tissue is disrupted and air leaks into the intrapleural space. And if this is pathology progress, that air accumulates in the pleural spruce and the affected lung collapses and alveolar collapses, and that leads to the reduced oxygen and carbon dioxide exchange. And the tension pneumothorax, it develops when there is one-way valve air leak occurs either from the lung or through the chest wall, and there is lung is completely collapsing and compressing the affected lung. And the mediastinum is displaced to the opposite side, that leads to the decreased venous return. And the most common causes of tension pneumothorax includes penetrating chest trauma, blunt chest trauma with parenchymal lung injury, iatrogenic injury, and mechanical positive pressure ventilation. And the patients mostly presents with tachypnea and dyspnea with distended neck veins. On clinical examination, there is hyporesonance or decreased or absent breath sounds on the affected hemithorax and the tracheal deviation to the opposite side. Tension pneumothorax. Yes, sir.
1 second, ma. Nishant, what's your question?
Sir, can you please tell us how to give an intercostal block, sir, for analgesia? Because
I generally use bupivacaine 0.25%, 10 cc syringe. Obviously, you mark the ribs where the tenderness is. Go to the lower border of the rib, aspirate and make sure you are not in the intercostal vessel, and then deposit about 1 to 1.5 cc or 2 cc posteriorly in the paravertebral region. So if say 5th and 6th rib is fractured, you infiltrate the 4th, 5th, 6th, if possible 7th rib lower border, like that. That will block the intercostal now.
Okay, sir.
Use a ropivacaine or bupivacaine long-acting local anesthetic.
Okay, sir. So even if it's an anterior fracture, we give it at the
In the paravertebral region, because intercostal nerves come from the paravertebral region, in the vertebra. Even when you are at the end of thoracoscopy, thoracotomy, we give paravertebral block, it's always in the paravertebral region.
Okay.
There are people under ultrasound guidance, they keep a catheter in the paravertebral region, and then you continuously infuse combination of bupivacaine plus fentanyl. That also gives a good analgesia.
Okay, sir. Thank you, sir.
Okay, continue, Indraja.
Yes, sir. And the tension pneumothorax, it is a clinical diagnosis and treatment should not be delayed. And the treatment consists of immediate decompression. There is, it is rapid insertion of the large bore cannula into the second intercostal space in the mid-clavicular line of the affected side, followed by the insertion of the chest tube in the fifth intercostal space. This is the image showing. Yes, sir.
Yeah, continue. Yeah.
Yes, sir. This is the image showing the insertion of the cannula in the second intercostal space.
The only suggestion I would add is use a Venflon, venous cannula, not a large bore needle.
Okay.
Because if you put the needle, as soon as the tension pneumothorax is relieved, the lung comes against this sharp needle, making multiple injuries and multiple air leaks. So use a IV cannula, relieve the cannula in the pleural space and take out the needle.
Okay.
That's a better way of immediate decompression. And then obviously you arrange a chest drain and put a chest drain.
Okay, sir. Okay.
Yeah.
Okay. And the open pneumothorax, there is a large open defect in the chest wall, which is around more than 3 centimeters, that leads to the immediate equilibration of the intrathoracic and atmospheric pressure. If the opening of the chest wall is more than 2/3 of the diameter of the trachea, then during each inspiratory cycle, air will enter preferentially drawn through the defect.
Okay, one second. Hari and Nishant are having a debate in the chat box.
Yes.
Tension pneumothorax, immediate decompression is in the second intercostal space, mid-clavicular line, right there.
Yes, sir.
ICD is in the fifth intercostal space, in the triangle of safety.
That current ATLS guideline says the decompression is not needed to be in second. It can be in the fifth, sir. Only for
Not need. Correct, but if you there is nothing to prevent you doing it, the decompression in the fifth intercostal space. It is changed essentially, meaning in the same space you can take out the needle and put the ICD.
I see. It's a bit more cumbersome. It's a bit more cumbersome to make the patient lift his hand and also.
Yeah, that's what I was coming to. Many patients with polytrauma will have upper limb injuries on the same side, maybe fracture humerus. It's very difficult to move that and find the fifth intercostal space and decompress, especially in a female with a large breast. Breast will be hanging into that space. Second intercostal space, mid-clavicular line is the best and instantaneous. You can do the decompression. That's practical. Okay.
Okay.
Thank you.
Yes.
And in case of open pneumothorax, air accumulates in the hemithorax with each inspiration that leads to the hypoventilation. If there is any valvular effect, this leads to the tension pneumothorax. The initial management includes closing the defect with sterile occlusive plastic dressing, and chest tube is inserted as soon as possible from the site away from the injured site.
Okay, Indraja, just wait there. First, you have to put a drain away from the open pneumothorax side, and then close the open pneumothorax. If there is contamination, you have to take them to the OT, clean, and then suture it. Not so simple. What if you are far away from the hospital and you see a patient with open pneumothorax? Anyone answer for that? Any answers? You are traveling in a bus or a car and you see an accident with an open pneumothorax. Can you do something about it? Because you don't have the facilities for a chest drain there. It is all mentioned in the good olden days Bailey law, not in the current one.
Just open with the...
Put a plastic sheet on the open wound side. And if you have a sticky plaster, stick it on 3 sides. Piece of plaster,
Okay,
put it all around, leave only one side for the air to come out. It acts as a valve. It doesn't prevent from air from going into that.
okay, sir.
It's a trick that is very simple. Rarely you get a chance or to do that, but it's worth. It may save one life if you keep it in mind. Occlusive dressing, any airtight dressing, all three sides you pack. One side you leave it open. There is a way for the one way for the air to come out of the pleural cavity, but it cannot go in because this acts as a valve, occludes it. Okay.
Okay.
Okay, sir.
Yeah. Go on.
In the massive hemothorax, the most common cause is blunt injury, which includes the contributing bleeding from the torn intercostal vessels and rarely from the internal mammary artery, secondary to the fracture of the ribs. And in case of a penetrating injury, also massive hemothorax will develop because of the injury to the viscera, intrathoracic and intra-abdominal organs also may be involved. And the patients will have unilateral absence of breath sound.
When do you classify it as massive hemothorax?
If it is more than 1000 ml of the collection of fluid in the intrapleural space.
When you put an ICD, you drain 1000 ml or more, or if it continues to drain 200 ml every hourly for the next 2 hours or more, it's a massive hemothorax, meaning they need intervention.
Yes, sir.
Hmm.
And on presentation, there is absence of breath sounds on the affected side in flat neck veins, and patients will be in the hemorrhagic shock. And the initial treatment includes correcting of the hypovolemic shock and insertion of the intercostal vein and intubation in the required patients. The initial drainage, if it is more than 1500 ml of the blood or ongoing hemorrhage more than 200 ml per hour, is the indication of the thoracotomy.
Indraja?
Yes, sir.
I think it is right that you mentioned the intercostal arteries and internal mammary.
Yes, sir.
But I think more importantly, the major intrathoracic vascular their injury is probably need to be kept in mind because they are the ones which bleed heavily.
Okay.
More than internal mammary and intercostal vessels.
Okay.
Basically, you know this much. If you drain more than a liter when you put an ICD, or if the patient continues to drain more than 200 ml hourly, it's time to call your consultant and take him to the OD. On table, you decide whether it's the intercostal vessel, internal mammary, it's a lung parenchyma which is stored, nor it is the SVC which is stored, nor it is bleeding from the right atrium or left atrium. I have seen all of that. You cannot make that decision clinically, but if you are draining like that, it's an indication to open. That's all.
Okay. Shall I continue? And the tracheobronchial injuries, this accounts for 1 to 2% of the all blunt traumas, and there is rapid deceleration with injury occurring 80% of the time at carina and distal trachea and urgent from the main stem.
Just hold on for a second. Nishant, what's your question?
Sir, like you told us, like in massive effusion, if it's more than 1 liter, we take them to the OT. We were taught, as in, I don't know if it's true, sir. If it's 1 liter, they asked us to clamp the tube so that whatever bleeding is inside, that only will act as a tamponade. Don't allow it to free flow. The patient might exsanguinate. So is that
correct? You are right.
Okay, sir.
You are right. If you have put an ICD in a patient with hemothorax and you have drained a liter and the patient is deteriorating, don't continue to make him bleed. Clamp it, at least that collection will act as a tamponade. You are correct. But if it's associated with major air leaks, like a tear in the lung with associated with pneumothorax and there are massive air leaks bubbling, then you cannot clamp it.
Okay, sir.
You get my point? If the bleeding is purely from the vessels or from the aortic tear or a venous tear, on the contrary, if there is a tear in the lung with air leaks plus bleeding, clamping is not advisable.
Yes, sir.
Oh.
Can I continue, sir?
Continue, please.
Yes, sir. And the esophageal injuries observed around 25%.
Indraja, tracheobronchial injury, esophageal injury, these are all very, very rare injuries actually.
Okay.
It's very difficult to diagnose. You need not cover all those things.
Okay.
Come to this slide, mediastinal widening. What do you mean by that? Pulmonary contusion, talk about it.
Yes, sir.
The isolated injuries to the tracheobronchia, esophagus, all those things are known, but it's very difficult. For your level, it is not required.
Okay, sir.
Okay. Pulmonary contusion, what do you mean by that?
Yes, sir. It is most commonly will seen in the blunt trauma patients, sir. It is associated with the plial segment and the fractured ribs. It is the injury to the lung parenchyma. And the natural progression of the contusion is worsening hypoxemia for the first 24 to 48 hours. And we can't find this on chest radiography, and CT is the confirmatory for the diagnosis, sir. And if the blood in the endotracheal tube is the sign of the pulmonary contusion. In case of mild contusion, we can manage the patients by oxygen administration, pulmonary toileting, and adequate analgesia. And patients with more severity require mechanical ventilation. And we should not restrict the patient, fluid restrict the patients in pulmonary contusion patients. Shall I continue?
Okay, hold on. Pulmonary contusion means like if you ever fallen from a bike, you guys get up and take the bike and go home only to realize that contused part in your body is swollen much more in the next day or two. Do you agree? Yes or no?
Yes, sir.
Similarly, if there is contusion in the lung, patient, if there are multiple rib fractures, more than one or two, always suspect lung contusion as a potential possibility. That patient will have a normal saturation at that point in time. X-ray also looks normal. But 24, 48 hours down the line, that intra-alveolar bleeding edema becomes more, resulting in hypoxia.
Yes, sir.
You will be wondering, I have seen him just 2 days back in the casualty, his saturation was all right. There was no hemopneumothorax. Comes 2 days down the line, you repeat the X-ray, there is no hemopneumothorax, but there is a white patch. That's not pneumonia, that's a contusion. It's because of the contusion, it's lung being filled with hemorrhagic exudative fluid. He is in breathing difficulty, gas exchange does not take place, that's why he is in hypoxemia. So always, if you see a simple rib fracture and discharge them casualty, please tell the patient in case of breathing difficulty, come back immediately without wasting time. That advice should always be given. Okay?
Okay, sir.
Yeah, it is recognizing that is more important. Once you recognize, even if you don't know, you can Google for how to treat it, or you can ask somebody who knows how to treat it. Okay?
Okay, sir.
Thank you.
Indraja,
Yes, sir.
if somebody who has got pulmonary contusion and you decided to ventilate them,
Yes, sir.
what is the precaution you take before you ventilate them?
Don't expect her to answer this question. Do you have any answer? For this, to answer this question, you need to know, yeah, there we go.
You need
Chest
Indraja,
tube
Ah,
must
yes,
be
sir.
good, and positive pressures, CPAP, pressure must be less than 6. Artha aita? Got it?
No, sir. I don't.
No, hydrogen, I mean, like positive pressure is more, it will cause a rupture and cause pneumothorax, right? Post
Yeah. Yeah. Tell them the ice intensivist that to keep the pressure below 5 or around 5 or 6, not more. And most of them will have hemopneumothorax, requires a chest air. Any other precautions, Ravi?
no, I think that's what they should know. You should intubate, you put the intercostal tube before you intubate them.
Shall I continue?
Go on, Indraja.
Yes, sir. Shall I go to the
Yeah. Mediastinum.
Yes, sir. And it comprises of heart, major vessels, trachea, and esophagus. And isolated mediastinal injury in blood trauma, most commonly associated, we notice injury to the aorta. In penetrating trauma, all mediastinal structures are equally susceptible. And the severity depends upon the anatomical location of the penetrating wound. And injury within the cardiac box, which is known as lined by the laterally by the midclavicular and superiorly by the clavicular and inferiorly by the xiphoid process. And the penetrating injury in this area has high risk of developing cardiac tamponade and rapid clinical decompression. In the pericardial tamponade, it most commonly followed by the penetrating trauma.
Compensation,
Yes, sir.
not decompression, it's decompensation.
Oh, okay, sir.
Okay.
And in pericardial tamponade, there is accumulation of the relatively small amount of blood into the non-distensible pericardial sac that leads to the compression of the heart, obstruction of the venous return, and decreased filling of the cardiac chambers during this diastole. And penetrating injury anywhere near the heart, and with patients who are in the shock, we should suspect the cardiac injury until proven otherwise.
A mediastinum, you had 2-3 more slides, isn't it? What happened to them? What do you mean by mediastinal widening? Only 2 slides, I say, reduced it.
No, sir, it is there.
How do you suspect mediastinal injury?
Sir, there is a widening of the mediastinum, sir, in the chest X-ray.
What do you mean by that? Anyone to answer?
Hari,
Sir, that width of that mediastinum in the X-ray is more, sir, like the length.
Aortic arch level, if it is more than 8 centimeters, meaning it should be measured in proportion to the patient in the chest radio. In a small film, X-ray itself is 8 centimeters. In a big film, it's not. It is measured on the console. Okay. In relation to the patient chest at the level of aortic arch. What are the causes for mediastinal widening apart from injury?
Sir, aortic aneurysm.
Pre-existing diseases, any mediastinal tumor, anterior mediastinal tumor like thymoma, lymphoma, germ cell tumor, or posterior mediastinal tumor like a schwannoma, pericardial effusion, not necessarily aortic injury. Any injury, even tracheobronchial injury, esophageal disease, can give you the impression of a mediastinal widening. But most common cause for mediastinal widening in a trauma patient is pseudo widening, because it's done in an AP view, not patient in erect position. Any patients whom you think there is mediastinal widening in this patient, then you evaluate with a CT scan, it will be normal. That's what I mean to say. But when you see a mediastinal widening on the X-ray, you need to investigate further. The basic investigation is a CT scan.
Okay, sir.
CT chest, preferably with IV contrast.
Okay, sir.
How do you deal with pericardial tamponade? Is there one more slide? Okay, go on.
Pericardiocentesis, sir, will do in the fifth intercostal space left of the sternum, sir.
I can't hear you, Indraja. Speak little louder.
Sir, this can be treated by needle pericardiocentesis. We have to insert the needle in the fifth intercostal space just left of the sternum.
I said that in the review, needle pericardiocentesis is advisable and is done and successful in patients with chronic pericardial effusion, like tubercular malignant pericardial effusion, where there is 500,000 ml accumulation. Needle or a catheter inserted into the pericardium and aspiration will do the decompression. In a trauma patient with cardiac tamponade, the amount of blood and blood clots is very minimal. You will not, and it is clotted. You will not be able to aspirate with a needle. You do need to do an operative, surgical. What is that?
So sternotomy or thoracotomy?
No. In the casualty, you can do subzified something you have written.
Subzified window, sir.
What is it? How do you do it? Any seniors? Hari, Abdul, Janani?
Never seen it.
Never seen it, but at least keep in mind. Even with or without local also, take out your Ziphied process. Once you take out your Ziphied process, next time when you are doing upper midline laparotomy, take it out and see for yourself. If you take out the Ziphied process, then you will see the diaphragm and pericardium. Make an opening in the pericardium. That clot, which is causing cardiac tamponade, will come out. That's all subziphied pericardiocentesis. Okay?
Okay, sir.
Next time when you are doing a midline laparotomy, upper midline laparotomy, take out the Ziphied process. There's nothing will happen, and feel and see the diaphragm and pericardium. That image, that memory should be there. Yeah.
Okay. Shall I continue, sir?
Yeah.
And
this is too much for you guys. Let's discuss if you have any questions.
Diaphragm.
Yeah, Diaphragmatic injury. Yeah, mention this. Yeah.
It is most commonly on the left side, sir, and because the right side is protected by the liver, and most commonly seen followed by the blunt trauma. And the defect in the diaphragm leads to the herniation of the abdominal organs into the chest cavity.
Okay.
Because of the negative pressure inside the thorax, these abdominal organs will herniate through the diaphragm into the thorax. And it can be diagnosed by chest radiography after the placement of nasogastric tube. But ultrasound and CT abdominal pelvis, or there is lack of positive and negative predictive values. We can see the after chest radiography, we can see the Ryle's tube in the chest, sir. This is the idea.
Okay.
Yes.
Basically, the diaphragm contour that you see on the chest X-ray, if that is missing, there is no continuity of the diaphragm contour. That's when you should alert yourself. Is it a diaphragmatic tear? Because it's a patient of trauma.
Yes, sir.
The only way to rule it out is to further investigation.
Yes.
Simple is the ultrasound. Ideally, CT scan.
CT scan. Okay.
Okay.
Yes, sir. And it should be repaired through the operative, sir, through the surgery.
There is no other way of managing a diaphragmatic tear. No more presentation. Any questions, guys? Open discussion. If you have any questions, queries, we can discuss. I would suggest, Abdul,
Yes, sir.
is our boy around Pawan?
Yes, sir, he's there, sir.
Give him a class on chest drains very next week.
Okay, sir.
Alter the schedule, because chest drain insertion, when do you insert, how do you insert is something that is very essential along with this topic.
Okay, sir.
Whenever you give this topic, either preceding or following that will be a class on chest drain.
Okay, sir. Fine.
Very crucial. Ask Pawan to do it. He is the master in that.
Yes, sir. Yes.
Maybe next week or sometime. Yeah.
Okay.
Any questions?
Sir, Nishant here, sir. Just one doubt, sir. Regarding that intercostal block, you said 10 ml we go on injecting. Is it 10 ml for all the ribs or 10 ml per intercostal?
Around 2 cc, 1.5 to 2 cc along the lower border of each rib. Depending on the number of ribs fractured, say 4th and 5th rib is fractured, you are advised to give a lower border of the 3rd rib, 4th rib, 5th rib, and 6th rib. That gives about 1.5 to 2 cc per block.
Okay, sir. Sir, is there any maximum amount of drug that we can give, sir? Like something beyond?
That's a basic entrance exam question, I say. With adrenaline, without adrenaline, how much of xylocaine that can be injected in a patient safely?
Okay, sir. Bupivacaine
up to 20 cc of 0.25% bupivacaine is safe. Beyond that, you need to calculate per kg basis.
Okay, sir. Thank you, sir.
I think another
Any other questions?
Rajashekar,
Yeah.
One teaching point for the students is, even with the acute thoracic injuries, you should suspect diaphragmatic injury. But in patients who have had blunt trauma of the abdomen, blunt trauma of the chest, which is not so significant, and then patient subsequently comes with some respiratory difficulty, again, to suspect undiagnosed diaphragmatic injury, which may not be very prominent at the time of the trauma, but then becomes later because of the negative intrathoracic pressure sucking the organ into the thorax. So many patients,
hernia becomes bigger and bigger, progressive breathlessness, and many of them are diagnosed the way you are saying it. Many of them are missed in the initial presentation because patient is not breathless. And then as it becomes bigger and bigger, progressive breathlessness, you end up diagnosing a diaphragmatic hernia. Agreed. Yeah.
Keep it in mind.
Yeah. If no more questions, thank you, Indraja.
Thank you, sir.
Well presented.
Thank you.
You had a wonderful preparation also. Appreciate it.
Thank you, sir.
Shall we call this close or any questions?
I think I have to tell you that your interjections and your advices to students are very prompt and extremely, practical. So I think round of applause to Rajashekar also.
Without that basic information, it will be misleading.
Yeah.
that knowledge, understanding will be incomplete. That's why I had to stop in between.
That's correct. That's good, actually.
Sir, one thing.
Yeah.
So today, 16 people had joined. So, like online for the class.
Okay. Okay. Number of participants,
Yeah,
16.
had
Okay.
increased.
Okay.
So,
Okay.
so that's what.
Can we, okay, follow this with a chest drain class very
Okay.
soon. Yeah.
Yes. So whether to keep it offline or online.
We'll see.
Keep it online. If
Okay.
more people attend and they want to learn, why not? Keep it online.
Okay, sir. Fine.
We can always repeat it offline in the OPD for our boys.
Okay, sir.
If it helps more people, keep it online. No issues.
Okay, sir.
Okay.
Okay.
Good night.
Yes.
Thank you, guys. Thank you,
sir.
Indraja.
Thank you, sir.
Thank you. Good night. Yeah.
Thank you, sir. Good night, everyone.
Good night.
Thank you, sir.